to teach stuff.
Well, absolutely.
So good stuff. Right. Listen, thank you very much for being here.
You're recording.
We are live on the Facebooks. Let's minimize that. We're live here in the room. Your recorder has started and you're broadcasting. I've hit all the buttons. I don't know what else could possibly go wrong today. Right. Nice to have you.
And,
welcome.
Welcome, everybody.
So we know you've got a hard finish today. So we will genuinely be in the quick fire round all day. So let's see how it goes. Looking forward to it. Okay, we're just going to get started. If you have any questions, please do bring them in. And we will go through them as quickly as we can, as many as we can. So here we go.
Is it worth just before we start, kind of summarising the mood music at the European Liver meeting? Because I think there were actually some important things about PBC. So, as people may be aware, it was the European Liver meeting last week in Vienna, and there is a lot of talk about where we go with PBC. So these are occasions when people all get together in the room to be able to talk about directions and challenges and where we think this all goes. And I think it was I've been watching all this for a long time, but it was very striking that I think the mood music has changed. And the agenda that in many ways the foundation has set is now taking hold. I think there were two things that were very conspicuous in the discussions. One is that targeting normal liver function is the way to go in PBC. And I think it's simply a matter of time before that becomes the goal for what we do. So move away from sort of multiples of the upper limit of normal, sort of an outphos of, as long as it's below 200, it's fine, to actually going for normal values. And I for one, and I know Robert does, think that's exactly the right way to go. So I think that's going to happen. And then the other is, after many, many years of trying to persuade people on everyone's behalf that symptoms matter and quality of life matters, there is a massive move towards acknowledging the importance of fatigue and memory symptoms, brain fog as a problem with patients. So the important thing is that we are all collectively winning. We haven't won yet, but we are, to quote Churchill, it's not the beginning of the end, but it is the end of the beginning, I think. And I think there is a sort of desire to just be better at what we do and not accept second best as okay, which I think we've all argued for a long, long time. So very positive, I felt.
No, it was, absolutely was. And it was good. And again, the respect for the foundation and what we're doing, and the fact that there is a conduit for the patient voice, I think it was really, really important. And to hear people like Alan Bonder, who we work with on these Q&As as well, but to hear him telling a room full of people that are there because they choose to be, that he prescribes the app, for example, for his patients, I think is immensely powerful. And it tells you.
So one of the themes that came out is the importance of tracking your symptoms, that actually one-off snapshots on any one particular day are less useful than actually a sense over a length of time. So how do you do that? Well, the answer is the app is how you do that. So absolutely, that this allows you to gain a sense, and for the clinicians to gain a sense. And particularly if you track symptoms over a length of time, it's very difficult for somebody to say, well, you're just having a bad day. If by that token, every day seems to be a bad day. So measuring, quantifying, showing people the impacts is very important.
Absolutely. No, that's brilliant. All right, thank you. And some of these features are going to come up in the questions. So which again tells us we're going in the right direction and working on the right things.
Yeah.
So first question, I've just been diagnosed with PBC. I've started Ursofolk. Yeah. Am I allowed to take supplements with this medication?
Yes, you are. Absolutely. So ursodeoxycholic acid is actually something that our body naturally produces. So it's one of those medicines that is a natural thing that our body produces, but for whatever reason, you don't have enough. So a bit like thyroxine that people with thyroid disease take. So basically, it will correct a shortage of it in your body naturally, which we tend to have in humans. So you're slightly altering the balance towards ursodeoxycholic acids, and if anything, it will help you absorb things from the diet. So this is why people sometimes put a little bit of weight on, which worries people. It isn't weight gain, it's weight returning to normal for you because you've taken away a tendency not to absorb food. So there is nothing, URSO has no interactions with anything, it has no problems with anything. You can take anything and everything else that you would like to take with URSO. It is the most robust treatment you can imagine. We tend to suggest to people to take it in the evening, and that's mainly because it will bind to questran if people take that. If people take that, which they often do, but other than that, you're absolutely fine with it. So many people take vitamins and various other sort of related supplements, so you're absolutely fine. And the starting, can't emphasize enough, the starting point for all PBC management, full stop, is URSO at the right dose. So the sooner you start that, the better. And there was a lot of debate about how quickly you can start it, and Gideon Hirschfield, that people will know very well, was saying, oh, he likes to build up a rapport with people and see them back in the clinic in 6 months' time and check their blood tests again. And if they've definitely got PBC, treat them at that point. And I'm afraid I don't do that. People leave the clinic on day one with a prescription, because every day you don't treat it is a day that you're delaying getting the right treatment in. So we chat to people, we look at the tests that the GPs have done, we start treatment, and we take it from there. So everybody with PBC should take or should try to take URSO.
Perfect, thank you. Okay, follow-up question on the subject of supplements.
Yeah.
Any supplements you can take to lower blood pressure and LDL cholesterol? Any advice for following berberine, NAC, or nattokinase?
Gosh, so LDL, so blood pressure, in essence, is very difficult to treat with supplements. And I think one of the things that we talk about, all the time is what are the things in human health that have really made a difference. And many occasions we've talked about vaccination, we've talked about clean water, and all. This is the history of medicine. But one of the other major advantages is blood pressure control, because certainly if you look at, my working life as a doctor, we used to see people with strokes all the time. And we don't see that anymore. And that's because of this sort of wide understanding of the importance of raised blood pressure. So generally speaking, if people have got raised blood pressure and it's real, and sometimes it can be just a little bit up because you're nervous going to the doctor or whatever. So my advice in those situations is just buy yourself a blood pressure monitor. You can buy them off Amazon. Other sales platforms are available for something like £30. They're very accurate indeed. And you can just put it on whenever you want, and it will give you really accurate measurements, much more so than going to the doctor. But if you've genuinely got elevated blood pressure, then you should have formal treatment for it, because it will make a big difference. In terms of the other supplements, they're all fine. N-acetylcysteine, NAC, is something that we use quite frequently. We tend to use variants of it. So S-adenosylmethionine is a variant of it, but they are all what are called antioxidants, and so they're all okay. Now, LDL cholesterol, so it certainly depends where in the world you are, but there are a number of foodstuffs that you can certainly get in the UK that naturally lower cholesterol. And if it's LDL cholesterol that's elevated, you've got to be a little bit careful with PBC, because sometimes it's the HDL, which is the good cholesterol. If it's LDL cholesterol, which is bad cholesterol, then again, as a way of controlling cardiac risk, it's useful to drop it. And that you can do by looking at diet and some of these sort of nutritional variants. You can get them in supermarkets, variants of butter and milk and things that will naturally lower cholesterol. And so it's less cut and dry. But I think if it's blood pressure, you need proper treatment. If it's cholesterol, it's reasonable to try lifestyle adjustments to see if you can bring it down. But if you can't, then again, it's sensible to take treatment for it. So people don't like taking drugs. But trust me, over many years of watching these things, it's far better to take blood pressure tablets than it is to have a stroke. And it's as simple as that. And remember, none of PBC doesn't protect you against any of these things. So anything that happens in the population is a common problem in our society, then it will happen in PBC as well. So, and as I said to the comment about URSO, there is nothing that you don't have to do or can't do in terms of treatment for these conditions because you've got PBC. So just generally speaking, don't put everything down to PBC, and don't let PBC make you pull the punches about managing other things. Okay.
Yeah.
I have high blood pressure. I take high blood pressure tablets. I don't like taking the tablets, but my missus sits me down and force feeds me them because she doesn't want me to have a stroke. And it's as simple as that.
Okay, perfect, brilliant. Thank you. That's helpful. Next question. So this doesn't allude to any treatments. I'm going to ask you about treatment in the question, but somebody was told that after diagnosis in 2017, they should be diagnosed for a DEXA scan, they should have a DEXA scan every 2 years, was diagnosed with osteoporosis late 21.
Yeah.
Bone density coming down each time they've been scanned. Should the scans be increased now is the question, but I'm also going to ask you about treatment for osteopenia and osteoporosis.
Okay, so just give me 2 seconds. I'm going to whiz over here because the door keeps banging.
While Dave's doing that, we had a question about the summit, and I'm just going to say that the Bare Facts, which is coming out either over the weekend or very early next week, is going to have a ton of stuff all about the summit, all about the next moves, what we're doing with it, and so that will be in there, and we'll share that with you. All right, Dave, over to you.
Okay, so we could actually have a round. It's a sort of common thing we talk about, which is things that we used to see that we don't see anymore. It's me getting it's me having been there, doing this for a long time. So as I've said many times to people, I did my first PBC clinic in 1991. So I've been doing it for 32 years. And it is really interesting to look at what the disease looks like now and what it looked like 32 years ago. And the most important thing is that it has changed out of all recognition. So PBC, we still have challenges with it, and particularly around symptoms and things. But this was a horrible condition 32 years ago. Over half the patients we managed were jaundiced. We used to see people who'd had 5 or 10 fractures. We just don't see that anymore. So that's really important, that if you ever think we haven't made progress in this disease, the very long view suggests that we have. Now, one of the things we used to see all those years ago was fractures. Okay, so we used to see osteoporotic fractures, in particular hip fractures and fractures of the spine. And it was because PBC itself would add to the risk of osteoporosis because of absorption of calcium and vitamin D, because of the liver disease. And it would add to the fact that the majority of PBC patients were women and frequently postmenopausal. So that's a group in society who are more prone to osteoporosis. So we used to see endless problems with that, and we don't see that anymore. And the question is, why not? Well, there are 3 factors. So the first is undoubtedly URSO helps because it helps you absorb vitamin D and calcium. So actually, I think just even being on URSO in itself has been helpful. Of course, in 91, we didn't have URSO. So it's yet another reason to take URSO. And the second reason is we now screen for it. So DEXA scan will be familiar to most people. There are variations of it around the world, but essentially it's an X-ray taken of the hip and the spine, where it isn't a picture that's taken at the end, it's a measurement. And the measurement is how dense the bone is. And the more dense the bone is, the less osteoporosis there is. So it's a way of measuring bone density. Now, it on its own doesn't give you all the information. So it's a value that gets fed into what we call a FRAX score, F-R-A-X, which is one of these risk predictors that looks at your age and your gender and all those various different things. So the DEXA scan measures how dense your bones are, and it's fed into this formula. And from that come recommendations for treatment. So being able to screen for osteoporosis is a major advance. And then the final one, of course, is specific therapies, which is what Robert was asking about. So what do you do if somebody is at risk of osteoporosis? Now, what's osteopenia and what's osteoporosis? So osteopenia is a mild form of osteoporosis. So osteoporosis is sort of identified thinning of the bones. Osteopenia is somebody who's on the pathway to that. So if somebody has osteopenia, what we do is do two things. One is to give them lifestyle advice to keep exercising, because that strengthens the bones. Don't smoke if you smoke, because smoking makes osteoporosis worse. And then to take calcium and vitamin D, because that will help replace the shortage that you have. So that's the standard kind of lower level therapy. If you are in the osteoporosis range, which means that you've got more sort of aggressive bone loss, then we specifically treat that. And usually these days it's with what we call bisphosphonate. So Fosamax is the one that most people are familiar with, but a number of different drugs that are similar to that. And what they actually do is stimulate the bone to become more dense. So they are very effective therapies. In the old days, we used to use HRT because that would strengthen bones. The sort of being postmenopausal for ladies, that will be a risk factor. So you can see how osteoporosis worked. How HRT worked, but we tend not to use that nowadays because there are more and better treatments for it. So DEXA every few years. DEXA every few years, and then if it's osteopenia, then lifestyle and calcium and vitamin D, and if it's osteoporosis, lifestyle advice, calcium and vitamin D, and then something like a bisphosphonate. How often should you get your DEXA scan measured? It depends on what the value is, and it depends what you're going to do. So if you've made a decision to treat somebody, then actually there's nothing to be gained by repeating it a year's time, because you've already made that decision. So the frequency will be highest if you are worried about whether or not you should treat it. So we scan everybody the first time we meet them, and then it's every 1 to 3 to 5 years, depending on what the value shows. So if somebody's got osteoporosis but they're not on treatment, they need it doing every year. But once you go onto treatment, it can go back to 3 years, because you need to give the treatment enough time to work. And generally speaking, there's almost no point in doing it every year, because the variation from 1 year to the next in terms of the assay will be probably bigger than any natural change in the bone. So it isn't a test you need to have done every few weeks, because it will just confuse you. But with all of this, I don't know which has made the difference. Something has. I actually have a sneaking feeling it's probably URSO returning absorption to normal, but we still do all the other stuff.
Okay. Ridiculous follow-up question, if I may.
Yeah.
The bisphosphates.
Yeah.
Are those for life or just for long term and then see what happens? Or
right, that's actually not a silly question at all. It's a very good question. So when we started using them, I think we all felt they would be for life because the risk was there. Obviously, what they do is they build bone, and you can go too far the other way, and it can actually end up with bone being brittle. Okay,
right.
So DEXA scans measure the density of the bone. Okay, they don't measure its strength, and that seems strange, doesn't it? But they don't measure strength; they measure how dense it is. Now, if you were to take some cast iron, okay, and some steel, the cast iron is denser than the steel. But if you drop a block of cast iron on the floor, it will fracture, and you drop a block of steel on the floor, it won't. So density and capacity to break are not the same thing. So too much bisphosphonate can actually end up with the bones getting a little bit brittle. And so nowadays we would tend to use it for about 3 to 5 years, then give people a little bit of holiday off it, and then recheck the bone density. So I think you can have too much of a good thing. So just think density and resistance to fracture are not the same thing.
Okay, perfect. Thank you very much. Question about gums. Somebody's got really bad pain with their team, but mainly their gums. They've tried gel, they've tried salt water, they've tried whiskey, which is often the answer, irrespective of the question. But genuinely and more seriously, often in tears with agony, sometimes they just have to rub hard and hold pressure to ease this pain. Something you're aware of, anything you can suggest?
So first question is, are the gums bleeding? So it's quite difficult without kind of seeing and knowing what they look like. So there are several things that would come to mind. So one of those would be periodontal disease, so where you get inflammation around the teeth. And that's often associated with diabetes. So you need to be aware of that. So diabetes check is worth doing. The second is obviously dry mouth can lead to gum infections, and so really good dental hygiene is very good, particularly if the mouth is very dry. And to be honest, going to the dentist, so people think of going to the dentist about teeth, but they also look at the gums, and they also look at the cheeks and the tongue. So they also look at the health of the mouth. So actually going to your dentist and getting them to have a little look at it would be quite helpful. There are some conditions where you get ulceration around the gums, but it's kind of difficult without seeing it, but it doesn't sound like it's that. So watch out for periodontal disease, which is what the dentist will look for. We do know that we used to see a thing called glossitis, which is where the tongue and the mouth is really uncomfortable. And that could happen with vitamin deficiency. So we've talked about supplements quite a lot. We talked about vitamin D deficiency, but you can get vitamin A deficiency and deficiency in some metals and things. So my other bit of advice is a good sort of general multivitamin would be very sensible, because we often see these sorts of these sorts of problems in people with a vitamin deficiency. So good oral hygiene, clean the teeth, be very careful about that. Go to the dentist, ask them to have a look, and a good quality multivitamin, and then take it from there. But it's very unusual to have that degree of pain, so it suggests there's something going on. So those have been my thoughts.
Perfect, thank you. I just want to clarify a point that's just come back on Facebook. So instead of damaging the bone density in the teeth, you actually think the urso's got more of a positive impact on the bone?
Yeah, I absolutely think that urso helps you absorb calcium and vitamin D, and is one of the reasons why bone problems are not as common as they used to be. Bisphosphonates, in addition to this density, brittle thing I talked about, they can also cause ischemia in the jaw. And again, we've seen that in a few people. So it's another reason. So I think urso returns bones to normal because it just helps you absorb calcium and vitamin D. But bisphosphonates help push it, beyond normal into, slightly abnormal the other way with the degree of calcium. So they are not a double-edged sword, but they're something you just need to be cautious with. And I think, being on them forever is probably not the way I would suggest it. And people, in a sense, don't like them being on for very long periods of time because of the difficulty. You've got to stand up and when you take them and swallow water and all of those things. So they're not the easiest thing in the world, but they do make a big difference. And as I said, can't pin down exactly what's worked, but something's worked.
Okay, perfect. Thank you very much. I'm going to talk about PBC and overlap syndromes. So the first of which is fatty liver disease. So they're two entirely different conditions. However, with 1 in 3 of the general population being affected with what we now call steatotic liver disease, obviously there's going to be a population of people with PBC that have this as well. So a couple of questions, if I may, on this. So the first one, I have a positive AMAM2. I also have fatty liver, and I've got elevated ALK phos. The hepatologist wants me to lose weight to see if the fatty liver is driving the elevated ALP. Started weight loss program and have lost 10 pounds thus far. So first off, congratulations on that. Yep. So the question is, do you have an idea of what percentage or how much weight loss you generally need before you start to see a difference in enzymes?
Okay, so that's a very good question, and that's going to become an increasingly commonly asked question. Now, in the UK, we don't see a vast amount of fatty liver disease in our PBC patients. So we don't see a vast amount, but in North America, the combination is very common. And they are, in fact, completely unconnected conditions. So one doesn't give rise to the other. However, they can cause a lot of confusion. And the reason for that is that the classic blood test of PBC is a raised alkaline phosphatase, which you can also get with fatty liver disease. And just to complicate it even further, you can also get autoantibodies produced in people with fatty liver disease, including M2. So it is perfectly possible to have the anti-mitochondrial antibody anti-M2 and a raised alkaline phosphatase simply from having fatty liver disease. Okay, so that's the problem. Now, how do you work out which it is? So I guess there are 3 points I would make with that. So the first is that the level of the autoantibody and the level of the alkaline phosphatase will often give you a clue. So it is, if you've got an autoantibody because of fatty liver disease, the values will typically not be very high, 1 in 20, 1 in 40. So a lot of PBC patients have 1 in 640, and that's not fatty liver disease. So that is a PBC antibody. So the first thing we look at is, does it feel like a fatty liver disease value, or does it feel like a PBC value? So that's the first thing, and that also applies to alkaline phosphatase. So a lot of PBC patients have got 500 or 600 for an alkaline phosphatase, and you wouldn't see that with fatty liver disease. It's about 150 to 200 normally. So does it feel like fatty liver disease? Does it feel like PBC? The second thing that you can do is additional tests that will help work it out. And the ultimate way to work it out is a liver biopsy, and we'll come back to that in a second. But also a test called IgM is quite useful. So this is a measure of the total amount of antibody in the blood. And there is one of the fractions of the antibody is called IgM, and that is always elevated in PBC, and it's elevated in no other conditions. And it's not part of the standard diagnostic test, but we tend to use it as a tiebreaker. So in this situation, I'd look at the IgM. The IgM is elevated, it's PBC. And if the IgM is not elevated, it would make me think that it was something else.
Okay.
The final thing is to say, actually, in a way, it doesn't matter, because all the treatments that we use for PBC are safe and or beneficial for fatty liver disease, and there are no treatments for fatty liver disease other than the agents we use in PBC at the moment. So, what are you going to do if somebody's got an ALK-PHOS and an AMA? You're going to give them urso because it's been trialed in fatty liver disease and it's helpful a little bit, and it's been trialed in PBC and it's helpful a lot. So either way, you're going to use it. So ultimately, how badly do you want to know, is it one, is it the other, or is it both, given that what you're going to do is going to be pretty much the same thing? Fatty liver disease can make fatigue worse, so it's associated with fatigue. So people who've got PBC and fatty liver disease will tend to be more fatigued, so that might be worth bearing in mind. And then finally, the actual question, which is how much weight loss do you need to have? It's about 10% is what you need to look at. So if you are 100 kilos, then you need to lose 10 kilos. If you're 60 kilos, you need to lose 6 kilos. Okay, that's a stone. So that feels about right. So you'll see if you lose 10% of your body weight, you'll see if it's fatty liver disease, see the blood test return to normal. If it's not fatty liver disease and it's PBC, it won't have any effect at all. So that's probably very useful. But to be honest, I would treat you with AMA. So I'd treat you with urso, full stop, see what happens, because it's going to be relevant in both disease types.
Okay, perfect. So there was my kind of follow-up question, is that many clinicians have reported fewer people with PBC than you would expect if you're looking straight across the population. So do we think urso has got something to do with that?
So in what sense, fewer?
Do we think that urso has got something to do with the fact that there are fewer people than you maybe expect with PBC, and do have that kind of non-related but just societal steatotic liver disease?
Yeah, I think that's a very good thought. I mean, I think that's a very good thought. So we've obviously used urso for very long periods of time, and so therefore, as I said at the beginning, we don't see as much fatty liver disease as we perhaps might expect ourselves to. And yeah, maybe the fact that we've been using urso for a very long period of time accounts for that. I mean, one of the problems we have is proving these therapies work.
Yeah.
And trials are very difficult. So at the moment, fatty liver disease trials are going through another of those difficult periods, because proving something works over a relatively short period of time isn't very easy. However, watching trends over 20 years does give you a picture. So that's what we call real world data. So when you've used a drug in the real world, what have you seen? I gave you some real world data about osteoporosis. In the real world, we don't see something we used to see a lot of. So why not? It's not the same as a trial, but it gives you a very long view to it all. So I think you're probably right. It's also, in the trials for fatty liver disease, it wasn't that great, but it had some benefit. But if you give it to people for 20 years, lo and behold, you don't develop fatty liver, would probably be a very good thought.
Okay, perfect. Thank you. So the other big overlap that we talk about with PBC is often AIH, or symptoms or features of AIH. And we've got a question. And so this is, again, we're just back from a liver congress, so we've got lots of thoughts and lots of things going around the head. And again, this is very much an underserved population. So first off, I want to acknowledge that and let you know that we're looking at this collectively, with a real focus. So I have AIH and I have PBC. After 10 years on URSO and AZA, I've now had to change to Cellcept with URSO. Also on steroids in parallel due to flare-ups. I'm 54. I'm getting fed up with having to manage the flare-ups. Is there anything else I can do?
So that's a really important question. So to rewind to the very beginning, is that PBC patients so PBC arises because of mistargeting by the immune system. So the immune system targets parts of the body it shouldn't target, okay? And that's nothing to do with your liver. In fact, the reason you've got PBC is nothing to do with the liver, it's to do with the way your immune system is built. So therefore, it's a little bit too keen to turn on an immune response, a little bit not keen enough to turn it off. So it tilts the balance, if you like. And so because it's not about the liver, thyroid disease isn't about the thyroid, they're both about the immune system, then if you've got one of those, then actually you're at increased risk of getting others, because those others are also related to the immune system. Okay, so that once you've got one autoimmune condition like PBC, there is an increased risk of getting other autoimmune conditions. And that's why dry eyes and dry mouth happen, Sjogren's. Now, one of the other autoimmune conditions that can happen in PBC is autoimmune hepatitis, which is another of the autoimmune conditions that affect the liver. Okay, so PBC is mainly attacking the bile duct cells. Autoimmune hepatitis mainly attacks the liver cells. Okay, and it's a very important condition. It's actually a more aggressive condition than PBC. And if people have got autoimmune hepatitis where the immune system's turned on the liver, you need to have treatment, usually with steroids and then drugs like azathioprine and Cellcept. And that is very important to know about and to treat, because otherwise that disease can progress quite quickly. So that's overlap where people have both PBC and autoimmune hepatitis, and you treat both of the conditions. So you treat the PBC bit with URSO, and you treat the AIH bit with AIH treatments like, as we said, steroids and azathioprine. So what's the problem? Well, the problem is actually a large number of people who've been said to have overlap, in fact, don't have overlap, okay? And the reason for it is that the clinical features that make you think of autoimmune hepatitis, we now recognize can be seen in a more aggressive form of PBC. So everyone here will be very familiar with the concept of URSO non-response and second-line therapies and obeticholic acid and things. And that's for people whose PBC is more aggressive. But when you look in the liver of people with more aggressive PBC, it looks like autoimmune hepatitis. So the blood tests and the biopsy findings that make people think of autoimmune hepatitis in PBC can also be a feature of more aggressive PBC. Without any element of autoimmune hepatitis. And over the years, before people appreciated this, probably far too many people with PBC got treated with steroids, often for long periods of time, without the disease ever resolving completely. So it grumbled away. And what we say to people is that maybe 8 out of 10 people labelled as overlap in the past probably don't have it. 2 out of 10 do have it. And so anybody who's got a diagnosis of overlap, you should talk through the clinician how certain are they that this is overlap. And there are particular combinations of blood tests that are said to be diagnostic of it. So you always look again at people with overlap to be certain. That involves looking back at liver biopsies, looking back at blood tests, looking back at so on and so forth. So it's worth asking that question. And if people have been on steroids on and off for a very long period of time, then that makes it more important to ask that question, because actually most people with autoimmune hepatitis don't need to be on steroids longer term. They tend to go on steroids and then we wean those out and they settle down, and azathioprine is enough. So your doctor usefully needs to look at all of the evidence, all of the why did they start you on steroids, what happened to your blood tests on steroids, and if needs be, repeat the liver biopsy now, because if the alternative is stopping steroids, then that's worth knowing about because of the risk of it. So biopsy we try and avoid if we can, but this is one of those situations where you need to. So many of the people who are thought to have overlap, in fact, are now on a beta-gallic acid or bezafibrate, and their condition has settled very well indeed. Now, if this is genuine overlap, and it does exist, I mean, it absolutely exists, it's just not as common as we thought it was, and you've been on prednisolone for a long period of time, then there are some other things that are worth thinking about, like budesonide, which is a non-absorbable form of prednisolone, which works in the liver. So there are some alternatives that give you a reduced exposure to steroids. It's worth having a little discussion with all of those with your doctor. You mustn't stop steroids, just one off, because that will get you into trouble. But it's always, we are working our way through everybody who's got an overlap diagnosis, and some of them have got overlap and a lot of them haven't, but it's always worth asking the question. So if you're on Cellcept and steroids and that isn't normalizing the liver blood tests, then it certainly may be worth trying something like a beta-gallic acid and seeing what that does to the blood test. And I've certainly taken a lot of people off steroids as part of this sort of regime change.
Okay, perfect. Thank you. I'm aware of time, so I'm going to go into a bit of a quick fire.
Okay.
And it's the PBC and. So we've got somebody who has good liver biochemistry, some symptoms, and they've got a lot of cramp. So is cramp related to PBC? Anything we could do to relieve it?
No, cramp is not linked to PBC. It's to do with fluid balance and salts in the blood. So just make sure you drink plenty. Make sure that if you're on water tablets, that you've got a balanced water tablet regime. And if in doubt, take some quinine, which helps settle it down. But it's not a PBC problem.
Okay, thank you. That's interesting, because we've had lots and lots of people with PBC talk about cramps in the workshops.
Yeah.
That's interesting. Okay, thank you. A sudden drop in serum B12, can that be related to anything PBC or just liver disease infection?
Yeah, so B12. So B12. So B12 is a vitamin, obviously, and it is absorbed. It is absorbed from the diet, and for it to be absorbed from the diet, you need to have something called intrinsic factor, which is a protein that is produced by some cells in the stomach. Okay. So when you absorb B12 from your diet, you can only do it if your body produces a certain protein to help it be absorbed. Okay. Now, it's almost impossible to not have enough B12 in your diet, almost impossible, because it is present in an awful lot of foodstuffs. So if your B12 is falling rapidly, it is almost never because you're not taking enough in the diet. Okay. It is usually because you haven't got enough intrinsic factor, and not having enough intrinsic factor is usually because you've got an immune reaction to that, which is an autoimmune condition, which can be associated with PBC. It's called pernicious anemia. It's a pretty horrible term, isn't it? Makes it sound terrible, but it's an autoimmune condition against the stomach that stops you absorbing B12. You can't treat it by taking a B12 tablet. Why? Because you take it off B12 in your diet anyway. It's the absorption system that doesn't work. So what you do is you need to give people injections of B12. So people have 3 monthly B12 injections, and that solves the problem. So if somebody's B12 has fallen quite rapidly, chances are that they've developed an autoimmune B12 deficiency. And to be frank, you don't really investigate it at all. You just put people on 3 monthly B12 injections.
Perfect. All right. Thank you very much. PBC and eyesight. Can your PBC affect your eyesight, or is this just getting old?
No, it wouldn't normally affect your eyesight. The exception to that would be very dry eyes leading to some corneal problems. So often people can get gritty eyes if you don't produce enough tears, and that can lead to eye infection, some glazing of the cornea. So that will be the only reason for it. And it's another reason to take eye drops to keep the eye, nice and healthy, so you sort of see properly. But all the other causes of eye problems, cataracts or macular degeneration or diabetic eye disease or any of those things, are not associated with PBC. So it would only be cornea, potentially getting dry and therefore a little bit of scarring. The other thing to say is that we talked about dentists earlier being very good at looking at all-round mouth health. Well, also opticians are very good at all-round eye health. So any concerns you have about eyesight, actually, the key thing is to get an optician's appointment. And the chains, the sort of Specsavers of this world, they have all the technology you want. They have better technology in many ways than the hospitals do. And so a normal eye checkup will not only look at your vision, but it will look at all aspects of your eye health. And most sort of a little bit of a loss of vision is just one of those things that happens. But there are some things like glaucoma you need to be really careful about. So if in doubt, get an eye check, and they will look at all aspects of it. And if you need to get proper referral and treatment, then the opticians will do it directly. So it works very well. So opticians are the right people to go and see for any sort of vision problem, even if you don't think it's short-sighted or long-sighted.
Perfect. Thank you. Okay. Now, next question is PBC and upper right quadrant pain. Linked or not linked?
Yes, linked. So when we talk about the right upper quadrant, left upper quadrant, think of the tummy between the ribs and the pelvis. And we split it into 4 squares, okay? So there's a line, notionally a line down the middle, a line across the middle, okay? And so to the top right of that, from your perspective, not when somebody looks at you, but for you, that's where your liver is, okay? So top left is where your spleen is, bottom right is where your appendix is, bottom left is where your colon is, and you get diverticular disease. So those are basically the kind of problems that you get in those 4 areas of the abdomen. And ulcers and things, and pancreatitis will be sort of in the middle. So in PBC, you get pain in the top right of the abdomen in 2 settings, okay, that are linked to PBC. But of course, there are other reasons why people get that pain that's got nothing to do with PBC. So there is a sharp pain that is to do with gallstones, and it's what we call biliary colic, but it's not like a colic. I mean, it's a bad term. It's a squeezy pain. So people often go, it gets worse and worse and worse and worse and worse over a few hours. and then people are sick and feel rotten with it, and then it relaxes over a few hours. So that's how it works. It's this squeezing thing, and that's to do with the gallbladder squeezing down on gallstones. Okay, so gallstones are commoner in PBC than they are in the normal population because of bile flow issues, and so gallstone problems are commoner in PBC than in the normal population, and so gallstone pain is commoner. Okay, having said that, we see far fewer in the way of gallstone problems than we used to, because again, our old friend urso slowly alters gallstone formation and means that gallstones progressively become smaller and less problematic. So it's another of these things that we see probably a bit less than we used to because of the effects of urso.
All right.
Most people with PBC don't have that pain. They have a duller, milder, but sort of niggly ache. And we think that's the capsule of the liver being stretched. So the buildup of bile within the liver stretches the capsule, so it's just a little bit tense because it's a little bit overfilled. And that often is a bit sort of uncomfortable if you touch the liver edge or you breathe in, but it's not a severe pain. And in my experience, that tends to be treated pretty well by getting the urso dose right.
All right, perfect. Thank you. Next one up. Somebody's 32 years old, been on urso for 6 months, not going through the menopause, at least we hope not, but severe night sweats and drenched. Could that be PBC? Could that be urso? Any thoughts?
So night sweats. Okay, so night sweats are not a feature of PBC. Okay, so you would not expect to see PBC patients having night sweats. And Robert, I think you'll attest to that. That's not cropped up as something that people have asked us about before. So that is not a PBC feature. So why might you be getting night sweats? There are two broad possibilities, and actually the way to answer that is for you to take your temperature. And the two possibilities are that this happens without your temperature going up, and that this happens with your temperature going up. So are the night sweats because you are hot, or are they not with you being hot? And it sounds counterintuitive that they might happen without you being hot, but that's what happens in the menopause and a variety of other things. Okay. Now, if you are getting a raised temperature when you've got sweats, then that needs looking into, because that suggests there is some form of chronic infection or something like that that's driving that. Okay. So you see that with abscesses, you see that also with things like lymphoma. So that needs looking into, but it's by far and away the less common possibility. So the first thing to do, I always tell people to do this in the clinic, take your temperature in the middle of one of these rampaging sweats. And your temperature will either be high or it'll be low. And if it's low, then, in a sense, it's less worrying. If it's high, you need some imaging to have a little look at where that's coming from. Okay. So why might you sweat if you don't have a raised temperature? Well, that is to do with adrenaline production. And we do see people with flushing and sweating with PBC. It's not usually at night, but that can happen because of the autonomic nervous system. The autonomic nervous system. So when you PBC patients have blood pressure, PBC patients have blood pressure regulation problems, and so that your blood pressure can sometimes drop when you stand up, and the body compensates for that by pushing out adrenaline, which helps the heart beat faster. So that can sometimes cause you to have palpitations, but it can also cause you to have sweats as well. But you never have a raised temperature with it. So there are reasons why PBC patients would have sweats. It's not usually at night, and it's to do with blood pressure. So just ask yourself, are you dizzy with it? So there is a comment come through about low-grade fevers. I think if you've got a raised temperature, you need to go and tell the doctor, by all means, say that you have spoken to me. That is not PBC, okay? If your temperature is up,
that is not PBC, and they shouldn't put that automatically down to PBC. So that needs to be investigated. First instance, it needs to be an ultrasound scan. Would be my recommendation. So, but feel free to say that you discussed this at one of these fora. But night sweats with a raised temperature are not a PBC feature. Full stop. Sorry, there's an ambulance going past.
You anywhere near a hospital?
Strangely enough, I am.
Who knew? Right, I'll keep going as quickly as I can. PBC and psoriasis.
Psoriasis.
Yeah.
Yes. Associated. To do with the genes that cause PBC. Okay. So the genes that are associated with PBC are similar to the ones that are associated with psoriasis. And they're the opposite ones to the ones for eczema. So eczema is very uncommon in PBC. Psoriasis is common. And it's a nuisance for some patients with PBC. Sometimes there are some treatments that are useful for psoriasis that are also useful for PBC. And we did some work a few years ago on the genetics of PBC to see if we could use genes to predict treatments that we hadn't thought of previously that might be useful in PBC. And in fact, that exercise identified retinoids, which are the modern era treatments for bad psoriasis. So they are associated. It's not usually a problem. We don't usually see what's called psoriatic arthropathy. We don't see the joint problems of psoriasis, but we do see more psoriasis than we ought to because they share a genetic risk set.
Okay, perfect. Good to know. Thank you. PBC and raised red blood cells.
So no, not associated. So there are several by raised red blood cells that can mean different things. So sometimes you can have a high level of hemoglobin within each red cell. Sometimes you can have more in the way of red cells than you should do. So that's a rise in what we call the hematocrit, which is the percentage of your blood that is red cells. So if the hematocrit is up, then that can happen because people are dehydrated. If you haven't got a fluid on board, then obviously there'll be more red cells than serum. So it can just be dehydration, particularly in a very warm summer. It can be caused by low oxygen levels in the blood because your body compensates by producing more red cells to carry what oxygen there is more effectively. You see it in people who've been trekking in the Himalayas because they adapt to the altitude by producing more red cells. So that will be a reason. But it can also happen with a few blood problems. So you can get what's called polycythemia, which is in Latin. So doctors are great. They come up with a Latin word. So polycythemia means lots of red cells, and it's used as a term to describe lots of red cells. But people say, oh, I haven't got raised red cells. I've got polycythemia, even though that's exactly what it is. So it depends what the level is. Drink plenty, see if it goes down with that. But if it stays elevated and you've not got shortness of breath and you've not been to Everest Base Camp, then you probably, again, need to go to the doctor and get a few things checked out with it.
Okay, perfect. Thank you. Now, I'm going to caveat this because we've got a couple of questions about cirrhosis. But again, I just need to caveat that with it that actually very few patients go with PBC go to full cirrhosis. So cirrhosis and peripheral blah 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 peripheral neuropathy.
So peripheral neuropathy is where you lose sensation in the skin, and it's one of those things in medicine that's quite complicated because it's about 101 different causes for it, and so you just need to work through all of them across the population as a whole. Then about the commonest is diabetes. So it's a feature of diabetes, and diabetes is associated with cirrhosis. So that would be an important thing to check for. You can also get neuropathy with B12 deficiency, which we talked about a little bit before, and also folic acid deficiency. So it's worth checking for those. You see it with a few drugs like phenytoin.
if people have had fits. You also see it with excess alcohol. So there are lots of things. It's not PBC per se. So what the doctor needs to do is to run through all of those options, but diabetes is the commonest. And diabetes is a bit complicated in cirrhosis because your sugar is often a bit spiky. The highs are too high and the lows are too low. So it's not a simple general elevation, which is what people tend to think about. People tend to think about, with diabetes. It can be a little bit more nuanced than that.
Yeah. Okay. Perfect. Thank you. Nosebleeds and cirrhosis.
Yeah. So nosebleeds will be associated because you get clotting, particularly with more, aggressive cirrhosis. You get blood clotting factor shortages. You also get low platelet counts, and each of those can predispose a little bit to nosebleeds. So it's not uncommon for people with cirrhosis to have problems with nosebleeds. We get the ENT people to cauterize them every so often. It's a bit like having a tooth out. You can get some bleeding from that. So it's not normally a problem, but it's something that can happen because of the effect of cirrhosis on clotting.
Okay, perfect. Thank you. Now, last one.
Can I answer a question that's popped up?
I want to come to that because I've got other question with regard to itch. So absolutely, 100%. Gave stomach or watermelon stomach.
Yeah.
Again, a link to cirrhosis.
Yeah, it's part of portal hypertension. So it's part of the elevation in pressure in the portal vein. So it's a first cousin of varices, if you like. And so it tends not to bleed in the same way varices do. But if somebody's got varices or they've got portal hypertension or they've got cirrhosis, then you can get watermelon stomach. Yeah.
Okay, perfect. Now we've saved it. We've got 3 questions in 3 minutes. So let's do this. CBD or cognitive behavioral therapy in itch. So I know I've got my thoughts, but Dave, what are yours?
Just 2 seconds. Yeah. So I wanted to answer this one because we've tried it. So cognitive behavioral therapy is mind over matter. It is the ability to concentrate out a sensation. Okay. And so when we say about itch, if people forget about the itch or don't notice it, then they feel much better. And what I always say to people is, can you feel your clothes today? And nobody on this call will have thought, I can feel my clothes today. That's because your brain filters the sensation out. But the moment I mention it to you, you feel your clothes. Okay. So your brain can filter in and filter out the sensation of itch. So would I ever use cognitive behavioral therapy for the management of itch? In PBC, no, not unless people were really, really struggling with drugs. We have used it in cholestasis of pregnancy, where pregnant ladies didn't want to take drugs but had terrible itch, and it works. It works. You've really got to want it to work, but it does work. So we've used it in that setting where people didn't want to take drugs, but it takes quite a lot of focus and concentration. So it is possible to filter it out, but I would tend to go for sort of gentle medical therapy in PBC. But I wanted to answer that because we've actually done it and it actually does work. And she was very happy. But you've really, really, really got to want to stick with it.
100%. And again, I would add to that I think it's certainly one of the tools in the armory. I think for short term, where it's just out of control that particular day, it's proven to be helpful. The Canadian PBC Society, they've got an Empower clinical trial. I say clinical trial, it's not a clinical trial, but it's proper research, it's double-blinded, it's all of those things, and it's looking at those kind of techniques and how they have an effect on symptom burden. So if you've not already joined the Canadian PBC Society, or indeed their Empower, then there you go. Really tight. So 1 minute on FibroScan. We've got a couple of questions. So one is, somebody's had a score of 9 and they've gone down to 4 and they're concerned if that's a genuine thing. Somebody's at 9, they've gone up to 11, they've been told they've got cirrhosis. So actually, is ultrasound the best tell? All of these kind of things. So just a little, if you can, before you go on imaging and PBC.
Okay, so FibroScan
for 1,000 people, on average, it's a very useful test. But the closer you get to an individual, the less useful it is, because you will get values that go up and down. It, again, does not measure how much fibrosis is in the liver. It measures how dense your liver is. It's just like a DEXA scan. Remember what I said about brittle is not the same as strong? So FibroScan is a little bit like that. So there are reasons why the values go up and down. So one is it's about the individual doing the test, whether they caught some of the rib in the scan, whether you'd had your breakfast, so on and so forth. So you can get values that go up and down. So a value change from 9 to 11 is not significant. Okay, so 9 is a little bit elevated, 11 is a little bit more elevated, but that is well within the range of the natural variation with a test repeated after a year. So I wouldn't read anything into that, but I would be wanting to repeat that every 6 months to a year to get a clear pattern. If it's gone down from 9 to 4, that usually happens because people are URSO, and so you've ended up taking some of the cholestasis away. So that makes the liver a little bit over swollen. Remember what I said about the right upper quadrant pain? It's because the liver is a little bit tense. And so that tends to be it. So FibroScan, I can't repeat enough. FibroScan is part of the picture to understand the disease. It's part of the picture, okay? But it is not the whole picture, and you shouldn't be a slave to it, okay? So we use it together with how people are, other imaging and liver blood tests to give us a whole picture. But it is not, you know, if it's now 11, you've got cirrhosis. Actually, it's not, 17 is cirrhosis. But, you know, some people talk about, you know, pre-cirrhosis and all of this, and 9 it isn't. That is ascribing too much significance to a value. It's trends over time that you need to watch out for. But watch out for it dropping. So it's falsely elevated very early in PBC when you first start therapy, okay, and it will drop. So in that situation, the four is normal, right? You know, you have some solidity to the liver, otherwise it would fall apart. So that's probably somebody going on to therapy, and then, you know, the liver becomes a little less inflamed. Probably the pain in the right quadrant goes away a little bit, and then the FibroScan drops to probably what is the true value.
Okay, thank you very much. I know you have to run.
I have to go.
I'm going to come in here. I'm going to say thank you very much. There are a couple of things that are really important, and I'm going to say them whilst Dave is still in the room. We missed a couple of questions. We always do. The fact that we always overrun with questions, again, tells us that we need to do this every week, and we'll keep on doing that. There are some questions that we just cannot ask in this format. So if you have an unanswered question, please email me personally, robert@pbcfoundation.org.uk, because these sessions are designed to give general medical information and not specific medical advice. And when you're looking for specific medical advice, we can take that to the board, we can answer your questions, we can help you directly, but we just cannot do that here. And I just wanted to say that in front of Dave. So on that note, thank you so much, Dave, for your time. Again, it's a pleasure working with you, and we will see you soon.
Absolute pleasure. Very enjoyable. We will always endeavour to answer questions, but some of them are honestly much better done offline, you know, privately, rather than in this, because often we'll need a little bit more information, if you like. But what we tend to do with the questions here, as you will have seen, is use them to illustrate a broader point, because these are all good questions, all sensible questions, but we just use them to inform, you know, more generally. So that's what we try and do. But great fun as always. Wonderful. And sorry to have to run away.
Go. Thank you so much.
Okay.
Good to see you.
Cheers,
all the best.
Everybody.
Bye now.